everyone. Let me wish you a very good evening from the University of Peradeniya, Sri Lanka. I am glad to welcome every one of you for the 8th pre-congress webinar of the Peradeniya University International Research Sessions 2021, organized by the Faculty of Arts, University of Peradeniya, together with the International Relations Office. It's my pleasure and privilege to welcome our resource persons today, Professor Lakshman Samaranayake and Professor Ruwan D.Jayasinghe. I am proud to announce that both of our resource persons today are products of University of Peradeniya. Thank you, sirs, for kindly accepting our invitation and sparing time with us today. As you are already informed, today's webinar is on a judicious topic, COVID-19 vaccines and oral health. COVID-19 has become a severe global pandemic with the emergence of a number of viral variants and increase in numbers of infections and death. It has already resulted nearly 200 million infections and 4.3 million deaths to date, causing huge economic as well as social upheaval internationally. Sri Lanka has just passed 4,500 deaths up to now. World has opted vaccinations as one of the strategies to control this pandemic. Efficacious vaccines are essential to prevent further morbidity and mortality. Due to the massive impact of the disease in vulnerable populations, multiple vaccines have been introduced in rather haste. Despite many promising outcomes of the vaccines, the efficacy and adverse effects are being monitored closely and discussed widely at the moment. Emergence of the Delta variant seems to be a challenge in the coming weeks, despite the rapid mass vaccination movements in Sri Lanka. The pandemic has placed substantial pressures on healthcare delivery to both COVID-19 and non-COVID-19 patients with other health problems. Oral health is one of the major health aspects, aspects that has been challenged, rather neglected by the pandemic. There is a huge risk of infection transmission during the delivery of oral health care because dentistry is often difficult to practice with masking and social distancing. Due to the relatively closed environment of dental clinics and the unique nature of dental procedures that generate aerosols, both dental healthcare personnel and the patients are at a risk of exposure to COVID-19 through respiratory droplets, aerosols, close contacts, and contaminated surfaces. Apart from the common clinical symptoms of COVID-19, such as fever, sore throat, dry cough, and myalgia, there may also be orofacial manifestations, including taste and smell disturbances, dry mouth, oral ulcerations, mycosis, and salivary gland inflammation which require dentist's opinion. On the other hand, patients with serious oral diseases such as oral cancer, pre-malignant lesions, dentofacial trauma, and infections are facing problems of getting appropriate dental care due to the threat and associated scare of infection transmission. On the top of this, dental clinical education is hampered because of the fear of infection transmission and the costs involved in the protective and preventive measures. In this context, this webinar intends to focus on two key aspects: COVID-19 vaccines, their vagaries and vacillations, and the practice and teaching of dentistry amidst the pandemic. Before handing over to our resource persons, let me explain the format of today's webinar. First, both speakers will deliver their presentations, and each presentation will last for about 30 to 40 minutes.
Hello.
After both presentations, there will be a question and answer session for about 20 to 30 minutes. Audience is welcome to post their questions during the presentations to the chat box so that they will be selected for discussion at the question and answer session. Now, let me have the pleasure of introducing the first speaker, Professor Lakshman Samaranayake. Professor Lakshman Samaranayake is an internationally renowned clinical academic with expertise in microbiomics, clinical research, senior executive level administration, and dental pedagogy. The author of over 450 scientific communications, cited over 27,000 occasions, and having an H index of 90, Professor Samaranayake has served as the executive dean of 2 major dental schools in Hong Kong and Australia at the Universities of Hong Kong and Queensland, respectively. With over 350 publications on oral fungal infections, Professor Lakshman Samaranayake is considered the foremost international authority on the oral microbiome. A highly sought after speaker, he has addressed professional bodies in over 40 countries and received numerous accolades for his research, including the coveted King James IV Professorship of the Royal College of Surgeons of Edinburgh, UK, and the Distinguished Scientist Award of the International Association of Dental Research. He has made personal donations of over rupees 3.5 million to establish research awards at the University of Peradeniya for research excellence. He has published over 25 articles on COVID-19 since the pandemic began and spoken at various international venues on the subject. Let me once again invite Professor Samaranayake to deliver his speech.
Thank you, Professor Sumedha Jayatilake, for that kind introduction. I would like to, before that, of course, thank the iPURSE organizing committee for doing this excellent series of webinars for the public as well as for the university community. And I am honored and delighted to be present today to give you a perspective of COVID-19 vaccines. And I mean, essentially the problems and the associated issues which we are facing with this COVID-19 vaccines, and also talk about this pandemic which is devastating to all of us. And so I'm really privileged to be a speaker today. And once again, thank you, the iPURSE organizing committee, Professor Jayatilake and Professor Panagoda and the others for the invitation. Now, although the presentation is on oral health and COVID-19, my presentation on COVID-19 vaccines is essentially on its vagaries and vacillations, in the sense that there's so much controversy in regards to the COVID-19 vaccines. So I would like to address that. In 90% of my time will be on that, but the last few minutes I talk about the dental aspects of it in relation to COVID-19 vaccines. Now, having said that, I mean, I can talk for another half an hour on dentistry and COVID-19 and various vaccines and infection control measures. So I'm not going to be into too much detail about it, but the meat of my presentation will be on COVID-19 vaccines. So without further ado, let's start our presentation. And yeah, as you all know, as Professor Jayatilake just mentioned, you know, everybody is going through this disastrous phase of various phases and various waves of COVID-19, first wave, second wave, third wave, fourth wave, and so on and so forth. And Sri Lanka, I know that, we going through a very, very difficult phase just now because of the Delta variant. I'll be touching on some of these variants in a minute as well. So one of the major ways by which we can prevent or we can, overcome this adversity is to have the whole world vaccinated. And as you will see later, you need to have 70 to 80% of the whole world vaccinated to have so-called herd immunity. But we shall go on to these statistics a little bit later. So this is how I'm going to, before I also, as Professor Jayatilake mentioned, I don't want to go into details of the COVID-19, and you can see the numbers here. The cases reported worldwide as of 2nd of August is 199 million. I guess it must be 200 million today. Total deaths reported is 4.25 million. And you can see the vaccines administered in 186 countries is 4.16 billion. So it's quite a large number, but you have to realize that you need to have at least 2 doses of the vaccine and so on and so forth. Right, so these are very, very, very summary statistics. And I'm sure that you must be fed up of these statistics as well. Day in and day out, you see these other statistics. So let me outline my presentation. Now, this is how I'm going to talk about. I will talk about some historical aspects of vaccines, because essentially the talk is about vaccines. And then it's important to understand as dental students and dentists and also the physicians, and also if a public is listening, the theory of vaccines, what is the meaning of vaccinations and how vaccines prevent infections. And then thirdly, we'll go into COVID vaccines and immunity. And finally, I have some take-home messages, which are essentially the most recent findings in the international literature and some conclusions. Okay, so let's get on with it. Now, the father of vaccines is thought to be, you can see the guy here, Edward Jenner, who in UK in 1796, in that era, described the phenomenon of vaccination. And what he did was, you can see here, on May 14, 1796, Edward Jenner, this was during the time when smallpox was killing millions of people all over the world. So what he did was, he also realized that the cows also have something similar to smallpox, and those who are milking cows, the ladies who are milking cows had something like smallpox, but they didn't die. So what he did was, he found this, and also these people had perfect skin and perfect health, and so he thought there must be some connection. So what he did was, he took a cowpox blister from one of these maids and scratched into the skin of this little boy, James Phipps, an 8-year-old boy. And after that, there was a small blister, and then on July 1st, he did that again, this time with smallpox matter. And then the boy didn't get smallpox, because virtually everybody got, if you came in contact with smallpox, virtually got smallpox. So this is a very basic. So then he called it vaccination, and that is the process we started. But I have got something else for you to say. China has beaten UK there too. You can see in that is more than 1,000 years before in China, the Chinese statesman actually did the inoculation against the smallpox by blowing powdered smallpox sauce into his son. So you can see this is in actually University of Pennsylvania Museum of History. So although people claim that Edward Jenner was the father of vaccination, this has been there in China to prevent vaccination long years ago. So a little bit of history there for you to understand this. Now, I'm just going to give you some introductory remarks on vaccines, but for that you have to understand, because people are talking about what are these vaccine trials, right? So what are these vaccine trials? So they are called 3 phases of vaccines, right? So they essentially, if you want to produce a vaccine for an infection, you have to do preclinical tests. So you can do laboratory and animal tests, right? Then you have 3 phases of the trials, which are called phase 1, phase 2, and phase 3. And safety trials are first done in phase 1 in a few guys with candidate vaccine, or a placebo or a cocktail. The primary observation here is to see the immune response and adverse effects. So this is done in about very, very few people. Then you do the expanded trials, which is done in about more healthy volunteers in the vaccine target population where they are at risk for the infection. So to determine reactions in a more diverse set of humans and test the different schedules. Then the last phase is efficacy trials, which is continue to monitor toxicity and immunogenicity in thousands of people, right? So this is shown very clearly in the next slide here, which is, here you can see the phase 1, very small number of people, phase 2, a larger number of people and hundreds of people, then the thousands of people, then only you apply for the FDA approval. And it's important to realize that, you know, so these trials give you only the efficacy of a vaccine. Now, there are 2 words I want you to remember. One is called the efficacy, and the other one is called the effectiveness. As you will see later, they are 2 different things. Some people think that they are the same thing. When I recently wrote to a journal, which a paper got accepted, even one of the reviewers didn't know the difference of it. So I had to explain this. Effectiveness of a vaccine has to be done in a very, very large population, about 10, 15, 20,000 people in a population where the disease is rampant. So therefore, the effectiveness of some of these vaccines, we still don't know, because our trials are, we introduced vaccines only a few months ago. So the effectiveness of the vaccines, the statistics are just coming in, because now only we are giving the vaccines, 2 doses of the vaccines to a lot of people. But we know the efficacy from the phase 3 trial, for example, AstraZeneca, for example, Moderna, and the mRNA vaccines of Pfizer, the efficacy is almost 96, 97%, and so on, right? These are from phase 3 trials. So I'm just to give you a background about the efficacy. Now, getting back to the COVID story, the finding of a vaccine within this short period of 9 months is a tribute to the ingenuity of the mankind and the scientific discoveries, and also the technological advances we have made over the last so many years. So you can see from SARS-CoV-2 was sequenced in 2019, and March, first SARS-CoV-2 clinical trials began, and within 9 months, we had a vaccine, right? So this is a really record for a vaccine, and even Dr. Fauci from NIH, they were saying that you cannot get a vaccine in 9 months, but we did get it. So many people have now joined this bandwagon of vaccine production, and you can see these statistics here. And you can see just very quickly, I got it from a website where they have this. You can see the phase 1, phase 2, phase 3, authorized, approved, and abandoned vaccines. So many people are going into this business. So we have just now 8 different vaccines on various platforms produced, right? And you can see 51. Still, there are so many coming behind, you know, and there is in this pipeline. So we'll see a lot of these vaccines. Thankfully, they are going to be hopefully better than the current vaccines, hopefully, and they can be kept at room temperature. You know that the mRNA vaccines are very, very difficult to be you have to kept at -40s and -80s and so on and so forth. So of course, some of these actually fall by the wayside, right? Okay, so moving on to next to the vaccine testing process. I don't want to belabor this point. So you have the limited approval first. Quite a lot of these vaccines are limited approved, then fully approved, and then paused or abandoned. Just a quick slide on this one. So what are the components of a vaccine? So essentially we have the active ingredient, so the viral or the bacterial antigen. That is the active part of the vaccine, right? And then we have stabilizers, and we have sometimes adjuvants called aluminum salts to boost the immune response. Sometimes when you give the antigen alone, it will not be so-called reactogenic. It will not create a reaction. So adjuvants are reactogenic for aluminum and so on. You can put, but for COVID vaccines, there are no adjuvants as far as I know, the COVID vaccine which are available. So then we have preservatives. There's a thing called, which is very, very commonly used, called thimerosal, and to prevent bacterial fungal contamination. Sometimes you put antibiotics to prevent bacterial growth, and there are trace compounds. So sometimes when you get vaccines, allergies for the vaccines, it could be due to some of these preservatives or trace compounds. So that is, but fortunately, our COVID vaccines, we have minimal allergies. So I am actually, there are so many different vaccines as you saw, but I'm going to focus on the current COVID-19 vaccines in Sri Lanka, which is the Pfizer, Moderna, AstraZeneca, Sinopharm, Sinovac, and Sputnik V, which, as you know, are done on 3 different platforms. So the Pfizer and Moderna are the most recently developed platform, which is called the mRNA in a lipid nanoparticle platforms. These are mRNA vaccines, right? Now, the other ones, the AstraZeneca, Sputnik, and Sinovac, are these two, in the green, are adenovirus based. And then the Sinovac is inactivated SARS-CoV-2. Now, this technology is pretty old, and we have been using this technology for polio vaccines and various other vaccines. So this technology, but this is the new platform, and that's why people are quite concerned when these mRNA came, and a lot of people didn't know because it did not have a 20-30 year history. Some of these other platforms have at least 20-year history of vaccination. Okay, so this is very, very quickly on this, but I want to just to touch on the COVID vaccination in Sri Lanka, and these are available in the various websites. So in the world, you can see doses administered per 100 people is 55. In Sri Lanka, it's 57. So we are doing a fantastic job with rapid vaccination program. And India, in comparison, I just put this for India in a comparison, is 35, because although they had the largest vaccine producing manufacturing organization, which is called the Serum Institute, they were really, unfortunately, they were very blasé about the disease at the very beginning, and they donated a lot of vaccine because in the first wave, they didn't have very many infections for some reason. But now they are in real trouble because they don't have vaccines for themselves. Anyway, that's a by the by. So in percentage of fully vaccinated people is 10%, and that's actually, as you all know, to reach herd immunity, we have to go about 70 to 80%, 70%. But now they have increased because of the Delta variant. Now they say we need to have at least 80% herd immunity because the Delta variant, as you will see later, is very, very vicious and more infectious. So these are the figures for the vaccinations, right? Here you go, and there are various websites. You can see in comparison to other parts of other parts. So we are almost equal to China, where almost all the people are vaccinated. Not almost equal. We come into the same color category. You can see, and Saudi Arabia and Sri Lanka. So these are the Southeast Asian region statistics. So, having gotten this historical outline, let's go into the vaccines theory. Now, I want to give you a basic, forgive me if some of you know about it, but some of you who are listening, who are like laymen, I just want to give you some idea in very simple terms how vaccines work. And this is how almost all the vaccines work, right? So in order to do that, first you have to know the structure of our enemy, right? So we are fighting this enemy, right? So if you want to catch a culprit, the police has to, if the police want to catch a thief, the police has to know what kind of person he is, what he was wearing, and what he was doing, what is his color, and so on and so forth. Similarly, our immune system, or the system which fights our viral and bacterial infections and fungal infections, have to know beforehand, if it were to stop that infection, what kind of a person or what kind of a body is infecting what kind of a virus is infecting. So essentially, they have to know what the virus is wearing, essentially, okay? So essentially, so virus has this spike of our guy, which is the SARS-CoV-2, has these various particles. I'm not going to go into various particles. The most important thing is the first part of the virus, which comes into contact with the human body. So what is the first part of the virus which comes into contact with the the human body or human cells? Are these spikes. They are like small flowers which are sprouting out of the surface of the viral particle, right? So these are RNA virus and so on and so forth. Now, I chose the analogy of a flower very carefully, because you can see it has a stem and it has let's say petals here. What are these petals? It has three petals. It has a structure which has three components at the top. And these are the petals which latch on to the antigen binding proteins of the human cells, as you will see in a minute. So you see, these are the so-called spike proteins. You can go back. So these are called spike proteins. I'll be telling that from time to time. So these spike proteins are critical, and so this is the structure of a spike protein. Again, you can see them here, right? So viral spike proteins, and so this is like a flower, like a small petal with a small flower with three petals, and so this is the binding type. This is where the virus binds to the human, so-called eukaryotic cells, right? The surface of the cell. So in human cells, okay, there are receptors which are called receptor binding receptors. They are called ACE2 receptors in the most of the human cells. I'll show you in a minute. These receptors have a liking to these spike proteins. So when they come together, it's like a magnet, positive and negative, and they just latch on to each other. And this is just a basic mechanism of how the virus latches onto the human cells and then starts infecting the human cells, right? So a little bit. So you can see these are the ACE2. So these are called ACE2 is angiotensin converting enzyme, right? So these petals latch on to these ACE2 and then merge with this is the human cell membrane, and slowly enters surreptitiously enters the cells, right? Releases the viral genome and multiplies inside the cells, and then assembles and releases the full viral particles, as you can see from here. I'm not going to go into details of this because it's not beyond the remit of this presentation. So that's a very basic life story of this virus, or most of the viruses. So ACE2s are the ones which actually help the virus they are the portal of entry. This is the door through which the virus enters the human cells, right? So you might think, okay, maybe some tissues in the body might not have ACE2 receptors, right? But you are mistaken. You can see in this slide here, lots of parts of the body, almost all parts of the human body, the tissues, heart, the lungs, the oral cavity, the brain, all these express ACE2s. And as a result, the virus can infect any of these. Because, for example, if you take an example of, like, for example, human immunodeficiency with HIV is a bloodborne infection. It has to come through the blood and infect through the blood. But this guy can come through the skin, it can come through the nose, it can come through almost everywhere. So this is why we have to clean our hands, and we have to be meticulously clean to avoid this darn infection. Okay, so this will give a good idea of everywhere in the body, any part of the body can essentially receive this virus. So any part of the body can act as a portal of entry. And this is very, very frightening and dangerous. And these are some of these viral particles coming out of these cells, human cells, budding viral particles. And these are from the Hong Kong University electron microscopy unit. So let me tell you how vaccine very, very basically stops this infection. Okay, so what really happens, go back to the basics, is that, so we have to tell our human cells, the immune system, which is the protective system of the human body, to recognize this organism, right? And to recognize this organism, as I said, to recognize the spike proteins, the S proteins. So we have to deliver the S proteins to the immune cells in various different ways. So that's why we have different platforms. Some of them are using mRNA, some of them are using dead viruses, and so on and so forth, right? So this is the basis of our immune system. They have to understand the form in which the virus enters the human body, the surface. So I've taken mRNA vaccine as an example. So the spike protein is coded in a messenger RNA. I don't want to go into details. I believe most of you know about this, but if so, it's the spike protein is coded in a messenger RNA. So this is the message which allows the immune cells to produce spike proteins in the human body, right? So this is the messenger RNA. So we have so we can't just inject the spike proteins into the body. What we do is they are enclosed in a lipid nanoparticle. So these lipid nanoparticles are in the vaccine here, mRNA lipid particles in the vaccine. And the vaccine, when you are vaccinated with mRNA, is taken by the system, the endoplasmic reticulum of the human cells, and they are presented as proteins to the sort of antigen presenting cells, okay? And then these antigen presenting cells, so now we have taken the spike protein, which is the red dot here, to the antigen presenting cells. So there are three types of immune mechanisms, as we'll see in a minute. So one mechanism is that they are called killer T cells. They are so called because they kill the cells in which when a cell gets infected, they focus on these killer cells and kills these cells. So that's why they are called killer cells. So they activate the killer T cells. So I said there are three components. Then there are cells which are called T helper cells, and also B cells. They produce antibodies. Now this is the very basis of the COVID vaccines, or any vaccine for that matter. They help to build your antibody levels in the body so that they can kill the viral infected cells very, very easily. Okay, so you forget about the killer T cell for the time being. We are now, what our vaccines are doing is to asking the body to produce antibodies against these viruses. So when they recognize the virus, the next time they come into the body after the vaccination process, they will start killing these viruses in this manner. Now remember, the antibody levels, as some of you may know, can go down. It can go down from hundreds, 200s, 3,000s even, international units to hundreds. So that is why we have this current situation with the COVID antibodies. The antibody levels are rapidly going down. I will show you this in a minute. So how does the body react to this situation? What they do is, there are things called memory T cells. These memory T cells remember the antigen structure and start producing antibodies, help the body to produce antibodies, even after your antibody level is low. So this is essentially the important thing. So these are the three mechanisms, basic mechanisms. This is very, very simplified, ladies and gentlemen. And so the activated killer T cells, the B cells, and the memory T cells are the very important thing in here. So for the next slides, when I'm explaining this, remember this slide. This is the basis of it for all of these, okay? So I'm going to talk to you about the next 10 minutes, the major COVID-19 vaccine platforms which we have in Sri Lanka. So before that, let me tell you, apart from the mRNA vaccines, there are mRNA vaccines, viral vector vaccines, and inactivated vaccines, which I mentioned earlier. There are other vaccines. There are things called DNA vaccines, which are new platforms. And then you have subunit vaccines, and then you have mucosal vaccines. I'm not going to describe these because they are not relevant to COVID. But I just want to mention just a couple of sentences on mucosal vaccines. Now, this will be fantastic if we get mucosal vaccine. What are these mucosal vaccines? I bet you remember if you want to take polio vaccines, you can get oral polio vaccines. You take your child to the doctor, and the doctor puts a few drops of the vaccine onto the mouth of the child, right? So that particular type of vaccines actually creates some kind of sort of subclinical infection in the mucosal gastrointestinal mixed mucosal system, and therefore orders the body to produce antibodies against polio. Or there are also mucosal vaccines which you can actually insufflate into your nose. It's like a spray which you put into the nose, and then the particles go through the nasal mucosa and their antibodies are developed. So the beauty of mucosal vaccines is once we have them, I know they are being developed. Two groups are developing mucosal vaccines for COVID-19. That means we don't have to get jabs. Because a lot of people don't get vaccinated because they are scared of the needles, and they think of all these needles are really, really scary. So I hope mucosal vaccines will come in the future. And as you saw, there are very many vaccines which are in the pipeline, and mucosal vaccines are some of these. Okay, so I just want to tell you that there are, apart from the mRNA vaccines and the viral vector vaccines and the inactivated vaccine, there are various other types which are available, which are going to come into use in the future. Right, so I'm going to talk to you about the vaccines which are available in Sri Lanka very, very quickly. mRNA vaccines first, okay? So I mentioned actually this, I don't have to tell you again. So the mRNA, what we do is we have the messenger RNA, as the name implies, a messenger to the human body, saying that I'm sending these RNA, you produce antigens which are similar to the viral antigens. So mRNA vaccines are the newest, simple, and elegant to insert, such as the spike protein gene of SARS-CoV to human cells. So as we know, mRNA vaccines over the last 6 months or so are proven to be very, very efficacious in preventing SARS-CoV-2. So technology, as I said, is based on mRNA ingestion by the immune cells. But here it is very important, as I underlined here, not integrated into the nucleus. Now, you know, there are, I don't have to tell you, there are thousands or millions of people who are against vaccination. because they think it's against their beliefs, their cultural beliefs, their religious beliefs, and also their political beliefs. They say that the vaccines get integrated into the nucleus, and then you will never get rid of the vaccine and its remnants. But it's not the case. At least if they are saying so, then you can say the mRNA vaccines never gets introduced into your nuclei of your immune cells, right? So it's all outside. It acts rather outside the nucleus. And therefore, it's not integrated into the nucleus as some of the vaccines, other vaccines you will see in a minute. So here we are not using so-called viral vectors. As you will see in a minute, the other ones, we have to use a dead SARS-CoV-2 virus or inactivated SARS-CoV-2 virus. So the production of here is production of a small chain of messenger RNA, small protein chain only. So you don't need very, very simple to develop and produce. So that's why mRNA vaccines are very, very popular and used like. So they are introduced into a lipid nanoparticle. As I said here, the mRNA has the code for the spike protein or the RB, the receptor binding domain proteins. So once injected, the lipid droplets are ingested by the vaccine cells. The protein-making machinery in these cells are instructed to produce viral proteins, which is the spike protein that are displayed on their cell surface. So the immune system then produces antibodies to these and is then primed to attack the invading virus and then inactivate the invader once they comes into when the human person gets infected through social contact or whatever contact. So that is the mRNA vaccine platform. So I am giving you some advantages and disadvantages of these three types of vaccines, mRNA vaccines. They are really advantages are rapid design and production. As I said, no highly infectious material are involved. Very, very good humoral and cell-mediated antiviral response. That means antibody response is almost 90%. Because it's not inserted into the nucleus, no insertional mutagenesis, no mutations, and large-scale production is feasible, as we have seen. And the other most important thing now, we are facing this secondary threat of viral variants, alpha, beta, lambda, delta, and all these things. And the new guys are coming along as called various, lambda and iota and so on and so forth. But anyway, so we can actually very quickly rejig these vaccines to attach to the viral, to attack the viral variants. And that's the beauty of the mRNA vaccines. So hopefully this is very, very hopeful, because once we get these viral variants like the Delta, I believe already the Pfizer is working on this, and they say their vaccines are very, very active against these viral variants. Okay, so these are the disadvantages. So the 1 minute. Sorry, back again. So I was talking about advantages. I skipped the slides. Sorry about that. What are the disadvantages of the mRNA vaccines? This is the biggest disadvantage, as you can imagine, in places like Sri Lanka and the tropics. -70 degrees, ultra cold chain requirements is, storage is almost impossible. It's very, very difficult, because we don't have the resources like in the Western world and developed world. So design has to be very, very careful. Now boosting may be necessary to achieve robust and lasting immunity. Now boosting is another big topic which has now been everybody is talking about. And the latest idea is that boosting may be necessary, whatever vaccine you get, the mRNA vaccines or other types of vaccines produced in other platforms. And a lot of people are scared because mRNA vaccines are newly produced vaccines, you see. So these are the disadvantages. The second one, so we got three. So we talk about the viral vector vaccines, which is your AstraZeneca and the Sputnik V, which is available in Sri Lanka. As I said, I'm not going to talk about other vaccines. So the Sputnik V is, this is done by the Camilla Research Institute in the USSR. AstraZeneca is done in the UK, right? So here what we have is, instead of mRNA, we have a vector. They are called vectors. We are inserting the SARS-CoV-2 genes in the form of DNA into a viral vector, another virus type. So these are adenoviruses. What are the adenoviruses? Adenoviruses are the common cold viruses. And some of these there are so many different adenoviruses, and we insert them into adenoviruses. So in the form of DNA, not the active principle, in the form of DNA, SARS-CoV-2 gene. And then the immune cells, when they encounter these, produce a protective immune response. Now again here, this viral DNA is not integrated into the host genome as falsely rumored. A lot of people think, again, this is going into the genome and can be cause insertional mutagenesis. That means the genome can be affected and you will be having a lot of other problems in the future for the next 10, 15 years. No, it's not the case. These are copied into the messenger RNA and directly translated into proteins. So there are various adenoviruses you can use. Common cold viruses are very, very common. It has been there for us for ages. We can use, this is the mRNA vaccines, okay? So you can see here, again, the same principle. What you do is you take the adenovirus vector capable of producing the spike proteins, right? Spike protein, which is a very critical thing, the one which touches the human body first of our antigens, and then they are injected into the human body. They are replicated of the virus, and then the antigen presenting cells take them and do three things: activate killer T cells, then produce antibodies, and through the memory cells they have the memory cells. So again, the same principle, right? Three major arms of the immune system are activated using the adenovirus vector capable of producing the spike protein. Okay, so it's very, very simple. If you know the first basics principles, you can apply that to all three. So the advantages of disadvantages of viral vector vaccines. Viral vector vaccines are years, more than 10 years or 15 or maybe 20, I can't remember exactly. Ruwan experience in the gene therapy field, strong antibody and cellular responses. They are viral vector vaccines. They do not replicate. No risk of chromosomal integration and resultant oncogenicity. Some people say that these vaccines cause cancers and so on and so forth, right? So these are all rubbish. So what are the disadvantages of viral vector vaccines? They cannot be used in immunocompromised subjects, as most of them have been exposed to these old adenoviruses, such as the common cold viruses. So they have the pre-existing immunity to this virus. So animal adenovirus vectors are there for use, like chimpanzee adenoviral vectors. So lastly, we come on to the inactivated or attenuated virus vaccines. And this is the Sinopharm and Sinovac. I think one of the commonest used in Sri Lanka. So again, inactivated or attenuated virus vaccines are very, very common, very old method, like influenza and hepatitis A vaccines are done through this. And then you have the, SARS-CoV-2 virus is inactivated by chemical means, so that is no longer infectious or able to replicate in human cells, right? In this case. So the viral antigens are intact and evoke a response, very good antibody response. As you can see here, this is done in the lab. You get the SARS-CoV-2 cells. This is where it's dangerous in the production cycle. You need to get live SARS-CoV-2 cells. they are inactivated and then injected, okay? And you can see the same thing, live attenuated or whole inactivated antigen presenting cells, take them up and then present to your immune system, either to produce activated killer T cells or T helper cells, which go on to produce antibodies and memory T cells. So basic principles are the same. So I don't want to belabor this point. So what are the advantages and disadvantages of activated and inactivated vaccines? This one, the pro and technology, lasting immune response, simple formulation, does not require adjuvants. So as I said, because it uses SARS-CoV-2, you need high biosafety containment facilities for their production, right? Inactivation has to be complete. You have to be 110% sure, right? That there are no residual infectious particles. Scaling up manufacturing, like for Delta variants and all these variants, very, very difficult. And then, of course, they require booster doses as well. So this is, for the variants, I think the mRNA vaccines are the easiest for the variants to be, the new vaccines to be produced. So next section, I'm going to go very, very quickly. Why do some important concept, why people react differently to the same vaccines, right? So now, very, very important slide here. You have to realize that the antibodies produced after vaccinations are divided into two classes, right? One is called neutralizing antibodies, and the other one is called non-neutralizing antibodies, right? So the gold stand of any vaccine producer is to produce neutralizing antibodies. So these are the ones which latch on to the spike protein and neutralize the virus. Non-neutralizing antibodies may be latching on to other parts of the virus, but they have minimal effect, whereas the neutralizing antibodies have the major effect of neutralizing the virus. So please remember that. So some people, depending on the individual, may be producing more neutralizing antibodies than non-neutralizing antibodies when the same vaccine is introduced, right? So that's one important thing. Now, this is the second important thing which a lot of people do not say, or even I have not seen this in a lot of documents or a lot of recent textbooks. When you are vaccinated, you get two types of vaccination immunity. One is called sterilizing immunity, and other one is called effective immunity. Now, in both these cases, the person who is vaccinated is immune from infection. So what is the difference? Now, in sterilizing immunity, the person is vaccinated and his immune response is so high, no single virus can survive on his mucosa or wherever it is, right? Whereas in the effective immunity, the viruses can survive on the surface of this individual, like in saliva, like in other body excrements, right? So now people say, okay, all these guys are vaccinated, but they are spreading the virus. True, because all the people do not get sterilizing immunity. Quite a lot of people, significant proportion of our vaccinees get only effective immunity. That's why they say that even if you are vaccinated, you have to wear a mask. You have to take social precautions. You have to wash your hands and so on and so forth. So this is very important concept for everybody to understand. And sterilizing immunity is actually very, very important. But it is hoped that whenever you get it, that you can get sterilizing immunity. And there are ways to check this. Of course, you can check it by checking saliva, for example, and seeing whether there are viral particles. But remember, you are safe because you have enough good antibody response. But you may transmit these viral particles to somebody else, somebody in your household, somebody who is immunocompromised. So this is a very, very important concept. I will just want to stress on this important point. So please remember that. So what are these vaccines? I mean, what kind of percentage of people are protected by these vaccines? Look at this top column here. Yeah. Seasonal influenza vaccines protects only about 50 to 60% people. So even if you are vaccinated, you will get the infection. Now, Pfizer is 95%. It's very, very efficacious. It's really almost a world record here. 95% is unheard of. And you can see the others. I'm not going to go through this. The point I'm trying to say is no vaccine will give you 100% immunity. So you have to take appropriate precautions. But the important thing, as you will see later, is these vaccines will prevent you getting severe infection and being hospitalized. So you might get mild to moderate infection like influenza, a little bit of greater than influenza. So this is why I put this slide here. So I got some other things on vaccines, which very clear I will go through, right? So these are vaccine efficacy and effectiveness. I told you about this before. Efficacy is what is done in the vaccine trials. Effectiveness is what's done in field trials. I'll show you that. Then vaccine choice, strain selection, pre and post-vaccination serology, non-responders and booster vaccinations. So I'm going to. So these are some of the intricacies and so-called vagaries associated with the vaccines, right? And this is shown here in this slide. Now, if you look at the vaccine efficacy, right? Once in green here, these are all depending on the individual. The ones in the blue here are depending on the vaccine related and individual related. So the vaccine, see how many factors are affecting the efficacy of a vaccine. Body mass index, comorbidities, the immune diseases or whatever, whether you're having diabetes, your race, your gender, your age, pre-existing immunity to different same type of viruses, whether you are having effective or sterilizing immunity, as I said, the things called immune imprinting and immunosenescence. I don't have time to go into these things, but the point I'm trying to get across is these are all the factors which affect vaccine efficacy. And then with regard to the vaccine per se, what you are injecting, so the booster doses are important, the timing of the doses are important, the vaccine strain is important, and the dose vaccine strain meaning vaccine platform, the dosage, single, dual, and so on and so forth. You know, Johnson & Johnson has only single shots. So they say now they might have to have 2 shots for the better efficacy. Anyway, so you can see the factors. There are so many factors determining vaccine efficacy. So let's get on to these factors. Efficacy varies from one vaccine to another, as I said. So these are the definitions I said earlier, right? So sorry about that. Percentage reduction of disease in a vaccinated group of individuals. In a vaccine trial ecosystem is called efficacy, as I said earlier at the very beginning of my presentation. Vaccine effectiveness it was called field efficacy. Actually, this is a better term. It's actually ability of vaccinate to reduce the disease in a vaccinated population over a substantive period. It could be 6 to 9 months or even for 1 or 2 years. This period varies. So this is why we don't have the effectiveness. So remember, there are 2 definitions here, efficacy and effectiveness, right? And then vaccine choice, which vaccine if given a choice, you know. Okay, I'm going to very important, the mixed mode vaccine administration. Now, at the very beginning, we didn't know if you do one with AstraZeneca and one from mRNA vaccine and one with attenuated vaccine, we can mix and match. Okay, so people at the very beginning said this can be done only in exceptional circumstances. Now we know that actually mixed mode vaccines appear to confer better immunity. You can get AstraZeneca vaccine and then you can get a mRNA vaccine. So you will watch this space. You will hear more about this in the future. So, and it's good for you guys as well. All of you are vaccinated, I believe, and including myself. I got the Pfizer vaccine. So we might have to get another type of vaccine done on a different platform to get a better booster, so-called synergistic response. And again, nobody knows the details because vaccines have been there only for a short time. So mix and match is good, and there's some data to show that. I don't want to go into details. You can get vector and mRNA booster, but when you boost with vector and mRNA, you can see here highly significant increase in the production of interferons at CD8 cells. These are from a Nature journal very recently. So there are lots of other questions in this context. Do you want to get your antibody levels checked? If one has contracted previously, the answer is no. We know that you can just take the vaccine. What about after vaccination? You do have to get serology. Is it essential? So, but again, there are so-called immunological correlates. Now, some of you as dentists and dental students have taken hepatitis B vaccines. After 6 months after the second dose, you have to take antibody level checks, and if it has to be 10 mega international units per milliliter. I don't want to go into technology, but so here we are checking the post-vaccination antibody levels. Do we have to do that for these vaccines? We still don't know. I think we might have to do that if we are doing clinics. What are we going to do with the non-responders, right? Okay, so we maybe give a third dose and so on and so forth, which we do with the hepatitis B vaccines, okay? Of course, booster vaccinations, now we know the latest data which is coming out the last week or so, they say that the booster vaccines are necessary. And then how frequently are we going to do it? Now we know that influenza vaccines boosters have to be given once a year, depending on the strain which is circulating in the region. If I am in the tropics, I have to get the one in the circulating in tropics. If I am in Europe, I have to get another one in the big winter, right? So these are some of the questions which are associated with it. So we have completed quite a lot of vaccines. We have got a good dose of the vaccines, right? What are some of the take-home messages? I'll take you through very, very quickly. These are very, very latest information. How good are COVID vaccines? So they are good, they are not perfect. Remember, they protect against hospitalization and death. So they are going to be like, you might get, if you're vaccinated, something like a very, very good dose of influenza, which you are in the bed for a few days. But fortunately, you will not have go to vaccine. So you get mild to moderate infection, not serious infection which goes to the hospital. So Taiwanese data indicate that 10% increase in vaccine coverage associated with a 7%, almost 8% reduction in case fatality. You can see this. There is hard data on this. Sterilizing immunity, can you remember that? Produced in a majority as opposed to effective immunity. This is very good news. So a lot of us have sterilizing immunity. That means we are not, although we are vaccinated and protected, we are not giving the infection to somebody else after the vaccination process. So vaccination was associated with almost 50% reduction in cases in household contacts. And it is anticipated that newer generation vaccines, once we get to know the technology, it will be even better, right? So what are the caveats? Evidence-based in Israel, US, and UK supplying the majority of the data up to now, yesterday, pertains to AstraZeneca and Pfizer, right? Estimates for the Sputnik V and Cytopharma Limited. So WHO has published so many of these. You can actually look at their quality and so on. So these results are coming as we speak. Okay. Are some vaccines better than others? Appears to be so, but there's a but. No head-to-head clinical trials have so far been conducted. So you need to do lots of clinical trials to say AstraZeneca is better than Pfizer or vice versa. Okay, but from what we have now, mRNA vaccines appear to be superior, and also we know that also vaccines generate a robust immune response. Now I say this all the time. any vaccine is better than no vaccine. So please get any kind of vaccine, because all these vaccines have gone through appropriate trials, and they are okay for anybody unless you are sort of immunocompromised and so on and so forth. So, okay, I mean, this is quite a detail, but I'm not going to go there. How durable is the protection? Again, little data. Pfizer have followed vaccinated for 6 months, and they have found a gradually declining trend in vaccine efficacy against symptomatic infection. But they all say overall they are highly efficacious. And then efficacy peaks at 96.2 months after a second shot and delivered gradually after 83.7 from 4 months. So these are some, quickly, I think I'm running out of time here. So let me just very quickly talk to you about Delta variant. Delta strain is the most worrisome so far. It's twice as transmissible as the coronavirus. Delta is becoming dominant globally, as we know. It's more resistant to vaccines than Alpha, particularly in people who have received first dose. Some opine that up to 80% of the community should be immunized, not 70% to get herd immunity. And then Pfizer appears to be more effective than AstraZeneca. So I'm not going to go into details, but just tell here that Delta infection associated viral loads are 1,200 times higher in infected individuals compared with original coronavirus strain. That's why they spread like crazy, like chickenpox. And then there are so-called breakthrough infections in vaccines, and Delta variants are common in these. So I think I'm going to stop here, but related to dentistry, I'm not, because there are not too many dentists. I'm not going to go into that. But I just want to show you this slide here. COVID-19 vaccine comparisons, right? Preventing hospitalization. Look at this yellow column here, 100%. Protecting from severe disease. Almost all these vaccines are fantastic. Protecting from milder disease, you get a little bit less, and so on and so forth. So this is the current data, ladies and gentlemen. And so I'm going to quickly go skip that slide. So as I say, no one is safe until all are safe, and this is very well known. And finally, this has now become an epidemic of the unvaccinated. You can see from US data and various other parts of the world, unvaccinated people get more, just going back to square one again. So I think with these remarks, I'm going to thank again the organizers for the kind invitation. And I think you'll take questions later. And this is my email. Actually, this should be a simple L, lakshman@hku.hk. If you have any questions, you can send me these. Remember again, small L, I couldn't put a small L here, Lakshman, my first name, @hku.hk. Thank you very much.
Thank you very much, sir, for your wonderful presentation.
Thank you.
We will come back to questions after Professor Ruwan's presentation. So let me invite our next presenter, Professor Ruwan Jayasinghe. Professor Ruwan Jayasinghe is the Chair Professor of Oral Medicine and Periodontology in the Faculty of Dental Sciences, University of Peradeniya. He is also an adjunct faculty in the Department of Oral Medicine and Periodontology, Savitha Dental College and Hospitals, Savitha Institute of Medical and Technical Sciences, Chennai, India. He has more than 110 paper publications in local and international journals and more than 170 international and local research presentations to his credit. He has received Sri Lanka President's Award for Scientific Publication in 2014 and 15, and National Research Council Merit Awards for 2016, and also Candy Society of Medicine Health Prize in 2020. He has written more than 10 academic texts and contributed to a number of book chapters. He is also the current director for the Center for Research in Oral Cancer and the Director, Operational Technical Secretariat, University of Peradeniya. He served as the Secretary of Specialty Board in Oral Pathology, Postgraduate Institute of Medicine, Sri Lanka. He had many positions in professional associations, including President of the College of Dentistry and Stomatology of Sri Lanka and Vice President of Sri Lanka Dental Association. He was a member to the Smokeless Tobacco Subcommittee of the National Authority on Tobacco and Alcohol in Sri Lanka, and he is a member of the Research Council of the National Institute of Fundamental Studies from 2016. He is also a consultant to the Asia Pacific Quality Network and a program evaluator for University Grants Commission, Sri Lanka. Without delay, please let me invite Professor Ruwan to commence his presentation.
Thank you, Professor Sumedha, for those kind words of introduction. I have an uphill task of keeping the momentum after a talk by a giant in the field. I will try my best to do the justice to the time given to me. I will be talking on the impact of COVID-19 pandemic in the dentistry. We know the COVID-19 pandemic has affected almost all sectors, not only in Sri Lanka, all over the world. Dentistry is not an exception. So it is very important for us to discuss how this pandemic has affected dentistry and the ways to overcome the issues that we are facing today. So in this presentation, I will be discussing the COVID-19 pandemic and dentistry, impact on clinical dentistry, impact on dental public health and preventive dentistry, impact on dental education, impact on dental research, the opportunities and way forward. We know most of the dental procedures generate aerosols. So therefore, dentistry has been recognized as one of the most important risk areas when it comes to the COVID-19 spread. There are 5 professions, healthcare professions, which are considered to be at a higher risk. And out of the 5, 3 comes from the dentistry and allied fields. So it tells us the dentistry, the issue that we are facing in dentistry. This generation of aerosols increased the chance of cross-contamination. And on top of that, the dental clinics are having a larger number of surfaces which can get contaminated. And these contaminated surfaces like our dental chair, the equipment that we are using, the surface, the floor, all these can act as potential sources for infection transmission. Therefore, adhering to the strict protocols, infection control protocols are essential in practicing the dentistry. In addition to that, there are some oral manifestations which present in people with COVID-19. And some of these presentations has been considered as one of the most important presentations in recognizing the disease clinically, especially the taste and smell impairment. The taste impairment can present in different ways, including the dysgeusia, hypogeusia, as well as ageusia. In addition to that, the patient may be complaining the pain and burning sensation. They can have disquamative gingivitis, ulcerations, aphthous ulcerations, glossitis, mucositis, and the patchy tongues. Few months before, there was a huge discussion regarding the involvement of tongue, and I'm sure you must have seen some scary photographs circulated in the social media, and most of the cases were not genuine cases, but still there can be some tongue involvement, and this tongue involvement is considered to be again a very important diagnostic finding. And there are some different aspects to the effect on COVID-19 in dentistry. We have a socio-economical and ethnic disproportions. The impact is not same all over the world. It is not same all over the country, all over the region. So there are some serious disproportions in the involvement when it comes to the dentistry. And all these effects on dentistry has given rise to a deterioration of the dental practice, not only in the region, but also the globally. there are costs involved, there are additional costs for the patient, and there are some additional costs for the dental surgeon, as well as lost income. And in addition to that, there is a lot of work-related stress. We know whenever we are doing a procedure, especially the aerosol generating procedure, we have to do that by having a full PPE. Wearing the full PPE is not something very easy, and it is very tiring, very difficult. At the same time, we are at a fear whether we will get the disease from the clinic. And this work-related stress has given rise to a premature retirement of many dental surgeons all over the world. Identifying and prioritizing the oral health care needs of people is very important. Because of the COVID-19 and some of the important oral health care needs of the people as getting neglected. So therefore, we have to consider that. And in addition to that, there are some ethical, moral, and medical legal issues we are facing with. So we will come to the impact on the clinical dentistry. As I mentioned earlier, the oral healthcare professionals are vulnerable and have a higher risk of transmission of COVID-19. The biggest problem that we are facing in the dentistry is the production of aerosols, which act as a source of cross-infection. There are some challenges in the clinical dentistry. So the first challenge that we are facing with when we are practicing the clinical dentistry is the spread of infection. And the spread of infection can happen not only through the patients who are having active symptoms. If that is the case, our life will be easy. We can recognize them and avoid doing the treatment for those patients, and we can take the necessary precautionary actions. But unfortunately, the spread can happen via the asymptomatic, symptomatic, and even pre-symptomatic patients, also from the patients who are in convalescent stage. And it can spread through the contact transmission. And it is very difficult for us to identify the super spreaders and limit them in the dental practice. The second challenge that we are facing with is the preparedness of the dental team. Knowledge, diagnostic facilities, prevention, vaccination, and treatment. All these are the concerns, the challenges. Number one is the knowledge. Are we having adequate knowledge regarding the COVID-19 and especially the prevention of infection in the dental clinic? We have done a small study using the dental surgeons in Sri Lanka. And according to the findings of this survey, the knowledge, and we did it at the very early stage of the pandemic. According to our survey, the knowledge of Sri Lankan dental surgeon is not satisfactory. It is not bad, but still there's a lot of room for the improvement. And what we have learned a year back is not what we know now. So this knowledge is ever increasing, ever changing, and we have to have a mechanism to keep our knowledge increased. So this type of webinars will be very helpful in this case. Diagnostic facilities. Do we have adequate diagnostic facilities to identify the possible cases, the risk patient, before we do a dental treatment? Is it justifiable for the cost? Is it justifiable for the risk? The prevention. We have to prevent the dental surgeon, the dental team getting the COVID-19 infection from the dental clinic. So we have to have a mechanism to do it. On one hand, we have to provide the treatment for our patients. On the other hand, we have to make sure that we prevent the dental surgeon and the dental team getting the disease. Vaccination. Do we have adequate vaccination for the dental team? Yes, in Sri Lanka, we are lucky in that sense. We got, all of us who are in the field, we got the vaccination at the very beginning of the disease. Now, if you look at in some other countries, dental surgeons were not included in the priority list, especially in the US. There was a big, the big discussion whether the dental surgeons need to be included in the list. And there were many states where the dental surgeons were not included in the priority list, thinking that the dentistry is not a field which needs the due attention. But then the policies changed and the dentistry was included, but not at the beginning. When we are doing the treatment, are we prepared to do the treatment in the correct approach? Are we prepared to do the treatment at all? There were people who are not willing to do a treatment at all. Forget about the aerosol generating procedures, even other procedures, there is some reluctance. And this reluctance comes with the first challenge, the knowledge. Then the third challenge is the changes to the dental clinic and the practice. Our dental clinic that we were having for long period of time is not suitable to do the practice under the pandemic situation. We may have to do some changes to our practice as well as to the clinic. Now, in order to do that, we have to have the proper knowledge regarding the virus transmission, and the way that the people are getting the disease. We may have to do some additional physical changes to our clinical practice. Triaging and management of appointments is very necessary. So rather than having the face-to-face interviews, face-to-face appointments and doing the triaging and trying to do the appointment management, and nowadays we have different technological modalities which we can use for this purpose. The PPEs, the personal protective equipment is very, very important. But at the same time, we must not overuse the PPEs as well, because we know the finding PP was very difficult at a time, especially when it comes to the N95 mask. There is a scarcity of the N95 mask, especially at the beginning of the pandemic. And even finding the gloves for us was not that easy. So therefore, what are the procedures that we are going to use? There are very clear guidelines on the use of PPEs in dentistry. What are the procedures and what type of PPEs we need for this type of procedure? The clear guidelines are there. And we have to practice those guidelines in the clinic. Otherwise, either we will be underusing it or we will be overusing it. The other problem is the attitudinal changes of the staff and the patients. There are two groups of people. One group of people, they are over-enthusiastic and they want to carry out the normal treatment procedures for each and every patient, ignoring the pandemic situation. Whereas we have another group of people, these are the two extremes. The another group of people who don't want to carry out any type of treatment because of the fear of contacting the disease. But we cannot have either of these approaches. We have to have a proper approach in managing the patients according to the standard guidelines and the protocols. The fourth the challenge is the knowledge. As I mentioned earlier, the knowledge is rapidly changing and advancing day by day. Therefore, it is very important for us to have the updated knowledge. What we have learned at the beginning of the pandemic is not applicable today. The things are changing every day. So it's very important for us to update our knowledge as quickly as possible. And the other problem, when we take our team, the team contains not only the dental surgeons, and we have other staff members as well. Sometimes the dental surgeon is having the adequate knowledge, whereas the other staff members, they do not have the adequate knowledge. I'm not trying to say both people must have the same knowledge, but they must have the adequate knowledge to carry out their work. So even a very minor staff member of the dental team needs to carry out some work, and those works are important and overall. So therefore, each and every person has to have the knowledge, not just knowledge, the updated knowledge. And then the policies of the government, institutions, and professional association. And these policies, guidelines, and protocols has to be updated regularly. Now, are we having that? Are we having the updated policies? Are we having the updated guidelines? Are we having the updated protocols? That is the question to be answered. Now, especially for us, it's not happening, and it's not happening in the same phase that we want. Unfortunately, during the pandemic, the dentistry has not been recognized as an important profession, not only in Sri Lanka, but not only in region, but all over the world. And therefore, certain things got missed because of that. The fifth challenge is the cost. And this is a very important aspect because the cost is affecting our profession overall. there are some additional costs to the clinic. As I told you earlier, we have to do some modifications to the clinic. We can't carry out the normal way. We have to add the personal protective equipments. We may have to modify our clinic, and we have to disinfect the clinic, this and that. So it is adding the cost to the clinic, and it is adding some cost to the patients. Now, most of the situations, especially in the private sector, they require a patient to undergo an antigen test prior to an aerosol generating dental procedure. So that cost has to be borne by the patient. And not only that, sometimes even the additional protective measures, they have to pay for that. So it will be additional cost to the patient. And thirdly, the socio-economic situation in the country and the world. The affordability of the patients are going down and down. And we know there are many places where the people has lost their income, and sometimes the people are not getting what they should get. So their income is either zero or it is less, and their affordability has become an issue. So all these factors is affecting the impact, the economy of the dental surgeons, dental clinics as well, hospitals, everything. So there will be some impact, and we have done a survey to identify the financial impact. And this was in 2020, late 2020, and there was significant impact on the dental surgeons. At that time, most of the dental clinics were not working properly. Some, they were looking after the patients who are having emergencies. Routine dental work was not practiced, and there's been a significant reduction in the cost. I'm sure by now the situation is much worse than what it was. The sixth challenge is the risk for dental surgeons. As we discussed over and over again, dental practitioners are having a high chance of carrying the infection, getting the infection from the clinic, unless we practice the universal infection control procedures. And the coronavirus has a high affinity to ACE2 receptors. And these receptors are highly expressed in salivary glands than the respiratory mucosa. Therefore, the saliva acts as a primary reservoir for droplet transmission. As we are working with the saliva all the time, this can cause a higher risk for the dental surgeons in getting the disease. On the same time, we have minimized the use of aerosol generating procedures from the day one. So therefore, the chances of dental surgeon getting the disease before the introduction of proper protocols and the guidelines, it was higher, but now it has becoming lesser and lesser. There are multiple studies conducted on this area, and there's a very good study conducted in USA, where the infection is very prevalent, and the people they have the highest number of infections as well as the highest number of deaths. And so they have conducted the survey, and this survey was a 6 months longitudinal study, and they have identified 2.6% of the dental surgeons has got the disease. And this 2.6% was not different from any other healthcare professional. So when you look at the dental surgeons, the chance of you getting it as a dental surgeon is not different from any other healthcare professional getting it. And these numbers were higher at the very early stage of the disease, but now the numbers are getting down and down. And in addition to that, there are some deaths reported among the healthcare professionals. So the dental surgeons were not an exception. There were some deaths reported among the dental surgeons as well. So all the deaths, so this the review, they have identified the reported cases, and they have identified 6% of the population, the deaths of the healthcare professionals, doctors, they are the dentists. So 6% of the deaths comes from the dentist. So we have to take adequate precautions to protect ourselves. The seventh challenge is managing the saliva. As I mentioned earlier, the saliva is a very important, significant reservoir of the virus. And whatever we do, there's a possibility of getting the droplets through the saliva. And these droplets are good source of airborne and contact transmission. One cough can generate around 3,000 droplets, and one sneeze can generate about 40,000 droplets which can travel some meters in the air. So while we are doing a procedure, whatever the simple procedure it can be, if the patient cough or sneeze, we are at a very high risk of getting the disease. And on top of that, if we are doing the aerosol generating procedures, the chances of having the disease is getting high. Unfortunately, the studies done on the salivary gland itself is very limited. They have done many studies identifying the presence of virus in the saliva, but not in the salivary glands. There are very few studies where they have identified the salivary glands and they have identified a very high load of virus in the salivary glands. That is why it is very important for us to have proper PPEs while we are doing the clinical practice. The eighth challenge is the ethical issues. Now, in one side, we have a serious infection, a global pandemic, and on the other side, we have patients who are having dental diseases. Can we defer our treatment during the pandemic? Can we defer our treatment during a lockdown situation? Can we defer our treatment because the patient is having COVID? Can we do that when the patient is after the COVID? So these are some of the questions that we have to answer. We have to weigh the ethics versus the risk of transmission, not only to us, to me, but to the people, group of people surrounding us, as well as to the society. There are some guidelines issued by professional organizations, and they have given a clear instructions regarding the management of patients, considering both these aspects. But whatever it is, all these are guidelines. So the moral decision to treat the patient has to be taken in light with the professionalism and the professional assurance. So we have to consider the professionalism and the professional assurance in managing the patient. We have to follow the infection control protocols, and we have to consider the safety of the dental surgeons, staff, patient, and general public. Ninth challenge is the consequence of withholding dental care. So as I told you earlier, there's a chance that we may not provide the proper adequate treatment for our patients. We know the dental professionals are trying their best to do the treatment for the patients, to provide some type of a treatment, if it is not the best, but at least some type of a treatment. But at the same time, we have to consider the possibility of virus transmission to the dental team and the public. We are obliged to follow the restrictions given by the public health bodies, including the Ministry of Health and various other organizations. And there can be some medical legal consequence of withholding care. And in a case where the patient comes into a clinical harm because we have not provided the treatment, and we may not have provided it because of the guidelines that the system is placing with. Now, if we are working within the guideline given by the healthcare system and the professional associations, and if there is a case where the patient got a complication because he or she has not received the dental treatment, are we liable for negligence or legal action? That is a question to be answered. I don't know. And if the guidance produced by the government authorities is not proper, it is not appropriate, there can be legal action against the authorities. We don't know. Our guidelines sometimes are not that updated with the knowledge, current knowledge. So therefore, it's two sides of the same coin. So we have to consider each and every aspect. So these are the challenges that we are facing today. Then the medical legal consequences. The patient is not getting the proper access to the treatment. So the access to the treatment is denied by a clinician. The patient wants to get a restoration done because the patient is having the pain or whatever, but we are not providing the restoration or whatever the treatment it is, because we have the guidelines and we have the fear of getting the disease and this and that. Are we at a risk of getting a medical legal issue? And then there are some treatments denied by the government. At the early stage of the disease, the Ministry of Health, the government issued a circular restricting the dental treatment only to the emergency cases. Whether it can cause a medical legal consequence, we don't know, and the time will tell us. The 11th challenge is the guidelines. So we have different guidelines issued by different associations, different agencies, government agencies, different institutions, organizations, professional bodies. Even though there are multiple guidelines, and these guidelines has been issued on multiple areas of the management in dentistry. Sometimes it is with the patients with suspected COVID, without the suspected COVID, patients who are at a lower risk of getting COVID. Now the question is whether these guidelines are getting updated regularly. What we had a year ago is not what we are having today. Now we are having the Delta variant, which is the most likely the prominent variant all over the world. So this Delta variant behavior is different from the Alpha variant behavior. So the guidelines that we have prepared considering the Alpha variant, are they applicable in the same sense for the Delta variant? On the other hand, we have people who have been vaccinated. Now, a year ago, we did not have that luxury. Now we have a significant amount of people who have received the vaccination. Now, are we considering these in our guidelines? So that is the question to be answered. Unfortunately, most of the guidelines we are dealing with in this part of the world, they have not updated regularly. But if you see in the slide, the CDC guidelines has been updated on July 13, 2021, considering all these aspects. So it can be considered as the most updated guideline. So we can use that whenever we have to. So what is the way forward in clinical dentistry? Only way is the effective infection control and the prevention. It is the need of the day. We have to carry out dentistry. We can't avoid the dentistry. We have to do it. And only way to do it is by having the effective infection control and preventive strategy. And it can be only successful if we are having a systematic approach in each and every component in dental sector. And it should be implemented in large hospitals as well as smaller clinics. The way forward, we can do things at different levels. There are certain things where that has to be done at the higher level, state or the ministry level. There are some changes, some policies has to be taken at the institutional administrative level. And there are certain things that we can do at the clinical level. It is good if we have a task force to deal with at the very high end, at the ministry level. So we have the COVID task force, but the COVID task force is basically considering the prevention of the disease, monitoring the patient, treating the patient, and all the aspects of COVID. But because of the COVID pandemic, the dentistry is in the receiving end. On the other hand, as it is in the receiving end, the patients are suffering, and with time, the patients will come with more and more problems. So therefore, how to overcome the problems, what we have to do, if we have some type of a body where we can discuss all that and come up with evidence-based policies, guidelines, protocols, and train the individuals and all this, it will be very helpful. So that is about the clinical dentistry. What is the impact on the dental public health and the preventive dentistry? Now we know the COVID-19 pandemic has become a testing ground for the public health, because all the epidemiological concepts came into action all of a sudden. During our time, we were not experiencing a pandemic, but here it came up like nothing, and all the concepts that we were thinking of, all the theories, we have to put it into practice. And the same thing applies for the dental public health as well. But unfortunately, the dental public health and the preventive dentistry, there's a very minimal attention into this aspect. Because the people, they are much more concerned about the COVID-19 pandemic, its spread and the prevention, but the dental public health got sidelined. Overall health promotion, education and prevention diseases, prevention of dental diseases, including the oral cancer, there's minimal activity or there are no activities. So for last 1.5 years, when it comes to this oral health promotion, education, preventive strategies, we are not doing much. We will see the result in years to come. So the next National Oral Health Survey or a study conducted on that aspect will tell us the impact on the COVID-19 on oral and dental diseases. FDI is drafting a policy document, role of oral health care practitioner during the infectious disease outbreaks, and most likely this will be approved in the next General Assembly, and that will emphasize the importance of having the continuous health care even under the pandemic situation. And it is very important for us to have such policy level intervention, otherwise the things will not move in the right direction. Preventive dentistry, there is a serious effect on the primary prevention, risk factor modification, cessation, public education programs are at a standstill or at a very minimal level. Now, even if we want to do it, it is very difficult for us to do it because the attention given to those type of messages by the public, health sector, as well as the media is very minimal. The people are more concerned about the prevention of COVID-19 than anything else. So the people, they don't take it seriously. But in certain areas, we can capitalize this. Now, for example, tobacco cessation, alcohol cessation, they are linked with the COVID-19 pandemic and the prevention of COVID-19. So we can capitalize on that and link them together and do the messaging to overcome the problems. And in order to overcome the problems associated with the preventive dentistry, we have to take some responsibility. Each and every dental surgeon, state as well as the professional associations must take some responsibility and come up with the strategy to overcome the problem. Secondary prevention, early detection is not happening well, but we have to consider coming up with the newer methods than going with the conventional methods. Getting the patient in, having a physical examination may not be practical in the current situation. So therefore, we have to consider the new methods, especially the teledentistry. Tertiary prevention, treatment at early disease. Again, we have to consider that and we have to do it. Otherwise, the preventable disease will transform and the patient will come up to us with untreatable conditions. As I mentioned earlier, the teledentistry is a very exciting possibility and it will be the way forward. And it is one of the opportunities that we get. So this pandemic has forced us to use the technology in the field. So therefore, now more and more people are practicing this, more and more people are doing research on this. So I'm sure with time, we will get the use of technology in dental field, especially when it comes to the preventive dentistry. mHealth, teledentistry, tools incorporating artificial intelligence, big data analysis, and the use of internet and social media for the prevention. These are some strategies that we can use for the betterment of the profession. Now, this is one example, the impact of COVID-19. So this data is from my own clinic. You can see in the normal times, we were basically seeing about 800 to 900 patients a month, new patients. And out of this, about 30 to 40 new patients with OPMD and cancer. And during the pandemic, the numbers has gone down to, first month it is only 1, second month it is only 2. So a serious reduction in number of patients with OPMD and oral cancer. That is not because the numbers has gone down. That is because the people are not coming into the clinic. Almost all the patients who are coming into the clinic during that time, they are the people with pain. Unfortunately, the OPMD and oral cancer, they don't have much of a pain, so they don't come to the clinic. And you can see some of the cases we have seen early, which were at a very early stages, they came late with which has transformed into the malignancy, or when they come to us, they were very late cases of malignancies where the treatment options were very minimal. Teledentistry will be the future. So therefore, it is something that we have to take very seriously. The teledentistry can be used for different purposes. We can use it for teleconsultations, telediagnosis, teletriage, telemonitoring. So there are many possibilities with the teledentistry, and we have to take it very seriously. And it can offer a new solution to start dental practice during the current pandemic. Need to incorporate or complement dentistry into our routine dental practice. There are some multiple challenges for the acceptance of teledentistry in the dental clinic by the administrators as well as the dentists and also the patients. So these issues has to be sorted out, and we have to sort them out urgently. And we can use simple social media platforms like WhatsApp or whatever it is for do some consultations. This may not be the best way, but at least we can get some idea. These people, they may not be able to come to us, and especially when we have lockdown, the people movements will be restricted. They may not have the transportation, but we can do something at early stage, especially the cases like OPMDs and oral cancers. And not only that, even simple thing which can get some fear into the patient, psychological things, we will be able to address by using these media. And we can use the artificial intelligence. I'm sure with time we will get many things, artificial intelligence based tools for the diagnosis and management. Thirdly, the impact on the dental education. Like any field in the dentistry, dental education is also get badly affected by the pandemic. Delivery, structure, evaluation, and future of dental education has been seriously affected by the pandemic. So this effect is not only on the clinical education. We see the effect on the preclinical education as well as paraclinical education. And the changes range from the fully online education, on the other hand, limited dental training. So some colleges, some institutions, they have gone into full online education and sometimes compromising the clinical skills. But whereas in some other places, they have limited dental training. So therefore, the students, they have to wait for some time to get into the training. There's a confusion in the dental teaching, especially in the clinicals, what to do and what not to do. Fortunately, the medical faculties immediately start to adapt to the crisis. So whenever the crisis came in, even like any other educational institute, medical faculties got affected, but they come up with various solutions to overcome the problem. But at the same time, we have to understand the dental education is not as same as the medical education. So dental education, especially when it comes to the clinical dentistry, we have procedures involved, and these procedures are mostly the aerosol generating procedures, putting the patient, dental team, and the students at a risk. So we have to have a balance, but that does not mean we have to stop it, and we can wait until the pandemic is over. One of the issues that we are facing with all over the world is the resistance to change. We have in the traditional systems of delivery, and there are situations where we are hesitant to change in the situation. So this is a challenge that we have to overcome if we are going to open up our dental schools, dental faculties, and come up with a mechanism to get it into the dental training. What are the challenges that we are having when it comes to dental education? There are many challenges. There are some challenges imposed on the faculty administration. The administration, they are the people who has to take the decision. So when they have to take the decision, they have to do it considering various facts. They have to consider the safety of the students, safety of the staff, as well as the patients. On the other hand, they have to deal with the higher authorities, administrative authorities. They have to follow the guidelines given by the state. So there are many obstacles for the faculty administration in deciding this. On top of that, there are forces coming from the staff and the students, open, not to open. So they are in a very difficult situation. And there are some challenges in teaching and learning, undergraduate teaching, clinical training. So all these aspects, as well as the postgraduate teaching, they are at different levels. The involvement is different level, but all these are getting affected. Then the assessments. Sometimes we change our assessment strategies from paper-based strategy to the IT-based strategy, but can we do that the same thing for a clinical case? It is not possible. So how are we going to do that? All these are the challenges that we are facing with. Then the effect on the student community, the effect of the pandemic on the student community and staff. There are situations where the student community as well as the staff are under tremendous stress, and there are work-related stress, and it can give rise to some psychological consequences as well in certain situations. And finally, the effect on the patient care. My last few slides, the impact on dental research. Like any field, the dental research is also getting involved. One of the biggest challenges that we are facing today is difficulties getting grants. No money, and not only that, the dental research has come into a low priority area. Almost all the granting agencies are finding it difficult to get the money because of the current economical situation in the world. And on top of that, the dentistry, the dental related research, the priority is given very low. If you are going to do some study in relation to the COVID, the priority goes up. So that is one of the problems that we are facing with. And then if you are going to do a study using the laboratories, it is very difficult to do the laboratory studies. Now, for example, we are conducting some studies in some cancer patients using the salivary sample, and to get this salivary sample centrifuge, we find it difficult to do in multiple places, because just because when you say it is a salivary sample, the laboratory say no, nothing doing, we can't do that, because they have a fear these salivary samples can transmit the infection from one to the other. And our environment in the laboratories are difficult to do this type of studies. So that's one issue. Then we have some safety issues, difficulties in recruiting patients for studies. Now, for example, if you are doing a clinical related research, getting the patients to do the study is very difficult. Or even if they come, they are not coming for the follow-ups, or they may not be willing to do it. And we are at the risk of getting the disease. So many problems. Extra cost, extra workload. And on top of that, the journals nowadays are having too many papers, and therefore the priorities are differs from one field to the other. So all these are the problems and the challenges that we were facing with when we are practicing the dentistry under the pandemic. But this pandemic has given us some opportunities as well. So this helped us to identify the weaknesses and gaps in our system. Our clinical practice, our research, our education, preventive strategies. So this gives an opportunity for us to identify. And it gives us an opportunity to identify the priorities. And it gives us an opportunity to incorporate technology into the dentistry. Using the online teaching, using teledentistry in managing the patients. So these things, we were talking about these things for some time, but without the pandemic, I'm very sure we will not go into this extent. So the things got much more advanced and quicker because of the pandemic. And it gives us some research and innovation opportunities. This is one area where we have not grabbed the opportunity well, but there are much opportunities for us to do the research and come up with some innovations. One, to overcome the problem that we are facing with. Two, considering the situation. And use of new technologies in the dental education, as well as new roles for the dentists. The dental surgeons, in certain situations, we show the world that the dental surgeons are not just the people who do dentistry. They are not just the people who can do dentistry or who must be limited to the dentistry. So we show the world that we can do much better work than that. And some of the dentists are involved with multiple things, even this COVID-related research, identification of the virus, developing the vaccines. We have the dentists in the team, and then getting the samples, doing the messaging, and many, many things the dentists were involved. So that comes to the end of my presentation. Thank you very much.
Thank you, Professor Ruwan, for the fantastic presentation. We have now reached the question and answer session. So let me get into the chat box and direct the questions. Okay, there were several questions. I have selected some. What is the difference? Sir, now the first question to Professor Lakshman Samaranayake. Sir, someone asked about the difference of different brands of vaccines. Actually, you have answered it in the lecture. So they want to know what are the differences among various brands or types of vaccines and what is the most effective one?
I think, yeah, thank you for the question, Professor Jayatilake. I think I responded to some extent. I have, in my presentation, I had the answers to that. But if you were to start talking about differences, actually, that my last slide was, I had rushed through that with a lot of columns. That was one of it. But I can tell you so far, the general consensus is that Pfizer, the mRNA platform vaccines, the Pfizer and Moderna, are so far by far the best, particularly because of its vaccine efficacy. But of course, you know, it's not easy to be delivered because of the issues associated with its storage and -40 and so on. So I frankly, I don't want to go to differences because I think that's part of my presentation. Probably he joined the lecture later on before I, yeah. So I think I will skip that section.
So can a person get vaccines of different platforms as first and second doses?
Yeah. So earlier there was again, as I mentioned earlier, there was a regulation guideline by the Department of Health in the UK saying that unless in a very, very rare situation when the other vaccine is not available, you shouldn't get it. But now they have relented, and now people have realized actually you can get vaccines on two different platforms. There's no problem. In fact, it's associated with a greater antibody response. So yes, you can do it. Those who have got Sinovac, for example, is Sinovac, which is common in Sri Lanka, right? It's Sinopharm.
Sinopharm is available.
So Sinopharm can get Pfizer. There's no issue with that. That's been proven to be pretty good. Yeah.
Sir, one more question. Will there be any deleterious cross reactions among antibodies produced by different vaccines?
No, because the antigen they are producing is against the same Sprotein, right? So in theory, there shouldn't be any cross reaction and immune complex formation or whatever. But I frankly do not think there's any. I mean, you see, this whole field is rather new. You know, I mean, even the different mixed mode vaccination has been there only for a few months. So far, I have not seen a single report where they had any deleterious reactions of mixed mode, so-called mixed mode vaccination. So, but you have to watch this space. I mean, these are developing as we speak. Things are happening. You know. Yeah. Thank you.
Okay, so thank you very much. One more question. Can you comment on the vaccine's efficacy in children?
Oh, yeah. So just now, again, their trials are going on because just now you see, when they did the initial trials, like at the very beginning, like 1 year ago, they were focusing only on adults above age 12 and so on, because it was the adults who were getting killed, like flies all over the world. So, but now they are doing the vaccine trials on children. And so again, the results are coming out. You have to watch this space. But I recently saw a paper, I think it is in Nature, that 12-year, the younger children, which are less than 12-year-olds, they have done a trial, and they found they also produce very good antibody levels. I can't remember which vaccine it is. So again, these are very preliminary reports coming out. Some of them are really not even referenced, reviewed. They are in, the pre-review publications. Yeah, they're coming up. So again, you have to watch this space. Those who are asking.
Yeah. Thank you, sir. One question to Professor Ruwan. Dental healthcare persons are at a risk of cross-infection, and the patients are scared of visiting the dentist due to risk of cross-infection too. So what is your opinion to link this gap?
Thank you for the question. And we have to understand the both parties. One, dental surgeons, they are at a risk of getting the disease. At the same time, they are a little hesitant to do the treatment at times because of the possibility of getting the disease. On the other hand, because of the publicity that we have given in the early stages, that the dentistry is a very field that it can spread very quickly, the people got the message in the wrong way and they are hesitant to come into the clinic, especially when they don't have any pain or aesthetic problems. And on top of that, the people are reluctant to go to any place, some of them. So therefore, it's an issue. So we have to educate both parties at the same time. From the dental surgeon point of view, from the dental clinic point of view, we have to have clear guidelines, clear protocols. This is what we are going to do and this is what we are not going to do. And these guidelines and the protocols has to be updated regularly. Now, if you take this situation in Sri Lanka, we have the guidelines which has been issued some time back and that has not been updated. So therefore, what we are practicing at that time, we are going to do the same thing today. So that is the issue that we are facing with. On the other hand, it is very important for us to educate the public, educate the people, educate the patients regarding the importance of getting advice in this pandemic situation, and especially in practicing the preventive strategies during the pandemic situation. The dental caries, periodontal disease, oral cancer, OPMDs, and many other dental problems are preventable diseases. So therefore, if they do the preventive strategies well, if we use this opportunity proper to educate the people to do the preventive strategies, then we can minimize the impact of the pandemic on dental and oral diseases. On the other hand, we have to educate the people regarding the importance of coming into the dental clinic if they have a serious dental problem. And we have to tell them what type of the problem that we are going to do, we are going to treat right now. So today the situation is this, and during this period, this is what we are going to do. And in a month's time, the situation may change and we may have to change our strategy during that time. So there has to be a continuous dialogue with the people, where the message has to go to the people continuously. And in addition to that, we can use these teleconsultations. For example, if the patient is having a lesion like OPMD, and rather than they coming into the clinic, we will be able to do a teleconsultations using something like a simple social media platform, WhatsApp or Viber, whatever. I'm not telling any special thing. Or even we can have a Zoom discussion with the patient. So we have the opportunities, we have the mechanisms to do all these things. It's the mechanism which is not in place.
Thank you. Thank you, Professor Ruwan. Actually, as Professor Ruwan mentioned, most of the dental diseases are preventable. So I hope the public should be educated in preventing those diseases by practicing basic preventive methods such as brushing and limiting sweets, because these days when children are at home, they may be consuming a lot of sugar and sweet products. Okay, So I think now we have reached our time limit. And before conclusion, let me thank once again Professor Lakshman Samaranayake and Professor Ruwan Jayasinghe for sharing your knowledge and expertise at this crucial juncture of the outbreak. Thank you for your time at this moment. I would like to thank all the participants who were with us online throughout, and also you are appreciated for raising questions from the speakers. It made a real brainstorming session. At last, not by least, I am thankful to the organizers of the iPURSE 2021 of the Faculty of Arts, University of Peradeniya, who provided this platform today. Your technical support group did a marvelous job, and it is very much appreciated. A special thanks goes to Professor Gihan Panavada, who coordinated the event from the dental faculty. With that thank you note, we will wind up for the moment. Stay safe and goodbye from Peradeniya. Ayubowan.